Good afternoon, ladies and gentlemen. Welcome to this second arrhythmia session of the day, which will be focused on mainly hot topics in the arrhythmia field. We have a really distinct group of international faculty. This session will be chaired by myself. My name is Ali Otto from Ankara, Turkey, and by Ali Boucheri from Kuwait. It's my pleasure to introduce first Professor Samuel Goldhaber from Harvard University, Brigham and Women's Hospital, United States, and he is going to answer a very important question of atrial fibrillation, primarily an electrical disease or systemic illness. Dr. Goldhaber.
Well, thank you, and good afternoon, everyone. It's a pleasure to be speaking at the Gulf Heart Association Conference, which is being held in conjunction with the Gulf Vascular Society Symposium. And I'm going to lead off this session talking about a very timely and somewhat controversial question. Atrial fibrillation. Is it an electrical disease primarily, or is it a systemic illness primarily? We'll discuss mortality and morbidity from AF, stroke burden, and this is a key point, the weak temporal relationship between atrial fibrillation and stroke. We'll talk about pathogenesis, cardiovascular risk factor management to reduce atrial fibrillation's frequency, and we're going to conclude discussing the importance of integrated cardiovascular care. Well, here we see in the pivotal trials of atrial fibrillation with the novel oral anticoagulants versus warfarin, that about half of the deaths from atrial fibrillation are cardiac, shown in blue, and about 30% are non-vascular. But I want to point out that only about 5% of the deaths are from stroke, and just as many deaths, about 5%, are due to bleeding. And the big intervention of the NOACs, the novel oral anticoagulants, is that they cut the fatal bleeding rate by 50%. We also see in this smaller study of about 9,000 atrial fibrillation patients that the deaths, the number one cause was heart failure, and the number two cause were deaths related to stroke. You see this green line here is the stroke-related deaths, and the orange line just above it is heart failure deaths, and just about that, above that, you see cardiovascular death. So stroke is not the number one cause of death in atrial fibrillation in this study either. And when we look at the Medicare data from the United States, Medicare means you're generally 65 years of age or older, looking at more than 230,000 patients. Whether we look at outpatients, shown on the left-hand side of the slide, or inpatients, shown on the right-hand side of the slide, we have the same message, that heart failure is the number one cause of death, and stroke and GI bleeding, gastrointestinal bleeding, both cause death at about the same frequency. And in the large registry called Garfield AF, the one-year outcomes in 52,000 patients show that death's the number one event. Congestive heart failure, shown at the bottom of the slide, occurred twice as often as stroke or systemic embolism. Now here we get to that very crucial issue of what is the time relationship, the temporal relationship of developing atrial fibrillation and having a stroke. And these data come from the ASSERT trial, in which all patients had a pacemaker or an ICD, which could record their heart rate and their heart rhythm. And what we find is that there were 51 patients who had a stroke or systemic embolism after a routine doctor's visit, but only 18 of these 51 patients actually had any evidence of atrial fibrillation when the recording was analyzed prior to the stroke. You would think that if they had a stroke, that 100% of the patients would have atrial fibrillation before the stroke, and of those 18 patients, only 4 of the patients had atrial fibrillation within 30 days of the stroke. Well, this really raises the question, does atrial fibrillation have any direct effect on the stroke, or is this more of a systemic illness? Is atrial fibrillation a systemic illness that predisposes patients to heart failure and to stroke? So on the left-hand side of this slide, you see the argument favoring atrial fibrillation as a focal electrical disease. If it is a focal electrical disease, then we would like to see a temporal association between the development of atrial fibrillation and the development of stroke. We don't see that. And we would like to see that if we give focal therapy for atrial fibrillation, such as medication or ablation of atrial fibrillation, that the stroke rate would go down. We don't see that either. If you don't use anticoagulation, the stroke rate seems the same. We would expect to see that the rhythm treatments are going to lower the risk of stroke, and that we don't have any proof of that either. So this really raises a lot of questions about atrial fibrillation as being a primary electrical disease, and then we have to look at the alternative hypothesis that atrial fibrillation is really a systemic disease, and that there are various risk markers for this systemic disease: obesity, metabolic syndrome, sleep apnea, diabetes, hypertension, and a sedentary lifestyle. And if we believe that atrial fibrillation is a risk marker for systemic disease, then we would expect that there would be a poor temporal association between the development of atrial fibrillation and the development of stroke, and that's what we see in the ASSERT trial. We would think that systemic therapy, in other words, treating the obesity and the metabolic syndrome and the sleep apnea, would reduce the rate of stroke. Treating the diabetes and the hypertension and the sedentary lifestyle would reduce the rate of stroke. And I'm going to show you some data to support that. And we would expect that the risk of a stroke, just by treating the heart rhythm, by ablating the atrial fibrillation, that risk of stroke would persist. So it's a different way of thinking about atrial fibrillation, leading to a new concept in atrial fibrillation management, that we have to have aggressive risk factor management. What does that really mean? That means we have to put more emphasis on reducing weight and increasing exercise because there's a global pandemic of obesity and metabolic syndrome. We have to treat hyperlipidemia because increase in lipids causes an inflammatory state. We have to treat obstructive sleep apnea because that is a predisposing cause of atrial fibrillation. We have to get the blood pressure under control, and we have to be very aggressive in treating diabetes. So that now when we deal with atrial fibrillation as a systemic disease, we're not just looking at the heart rhythm of atrial fibrillation. All right, well, what about lifestyle? Does lifestyle have anything to do with developing atrial fibrillation? I'm going to point out this paper that just appeared in the European Heart Journal. And I think that most of us here in this room, we work so hard delivering health care, and we work so many hours, and most of us work 60, 80 hours a week. This study showed that if you work more than 55 hours per week, you have a 42% greater than average risk of developing atrial fibrillation. Your risk of developing atrial fibrillation is as high as if you have hyperthyroidism. And it's about the same risk as if you have myocardial infarction or obesity. It's higher. Working more than 55 hours a week is a higher risk of developing atrial fibrillation than having high blood pressure or diabetes. Again, these are hallmarks of a systemic disease rather than focusing only on the rhythm of atrial fibrillation. So in this study, as you see in the graph on the top of the slide, there's basically a dose-response curve. The more hours per week that you're working, and I've spoken with many of you, I know how hard you are working at your jobs, the more likely one is to develop atrial fibrillation. And it doesn't matter, the lower half of the slide you see the same data shown in the way atrial fibrillation was discovered. It doesn't matter whether it was a study of electronic health records or electrocardiograms, the message is the same. Now here's another problem. Fat is an emerging player in atrial fibrillation. The epicardial adipose tissue causes inflammation. Inflammation causes, in part, atrial fibrillation. And that's why reducing risk factors such as obesity and metabolic syndrome is so important. You get inflammation, and then you get a transition from fatty cells to fibrotic infiltrates, as you see in the lower right-hand portion of the slide, and that fibrosis will lead to atrial fibrillation. Okay, well, we always think of treating atrial fibrillation with drug therapy and with radiofrequency ablation of the atrial fibrillation, but are there other approaches we can take as well? And let's look at this very interesting study from Australia that was just published. Their atrial fibrillation clinic, staffed by electrophysiologists, actually did risk factor management, weight management, increasing physical activity, treating hypertension, managing glucose intolerance, treating high cholesterol levels, diagnosing and treating sleep apnea, and working on cessation of cigarette smoking and reduction of alcohol. Well, what they did was a randomized controlled trial in their electrophysiology clinic in Australia, they randomized patients to aggressive risk factor management or to routine care. And what did they find? On the left-hand side of the here of this slide, you see the lower group. RFM is risk factor management. Ablation-free is the group that is the higher line here. They had the aggressive risk factor management. The lower group needed a lot more ablation. And on the right-hand side of the screen, we see the higher slide, the higher line here. Risk factor management is the group that had total freedom from atrial fibrillation compared to the control group. This tells us that risk factor management really does matter. Okay, let's look at the Women's Health Study and the development of heart failure and its effect in atrial fibrillation. First of all, if you're a woman with atrial fibrillation and you develop heart failure, number one, your all-cause mortality increases by 83%. Your cardiovascular mortality, shown in the middle here, almost triples in frequency with heart failure, and the rate of myocardial infarction is 5-fold higher if you develop heart failure. So you really don't want to develop heart failure if you are a woman with atrial fibrillation. Well, what they did in the Women's Health Study is they looked at risk factors that could be directly modifiable, and they looked to see what effects those had. Let's look first at cigarette smoking. The current cigarette smokers had a double the rate of heart failure. Those women who were obese, with a body mass index greater than 30, they also had a double the rate of heart failure. Those women who had a systolic blood pressure greater than 160 millimeters of mercury, they had a double the rate of heart failure. And when you were able to modify the risk factors and get the smoking stopped and get the body mass index not necessarily back to normal, but even to between 25 and 29, and you can get the systolic blood pressure down to 120 millimeters of mercury, the risk factors for heart failure was not above the normal expected risk. And this is in contrast to the other significant risk factors that could not be modified, shown at the bottom of the slide: increasing age, chronic kidney disease, or concomitant coronary heart disease. So again, here we have another study showing the importance of modification of risk factors. And here you see the impact of risk factor modification on heart failure risk in atrial fibrillation from the same study. The risk factors that they tried to modify were blood pressure, body mass index, diabetes, and stopping cigarette smoking. If you had two risk factors modified, you reduce the likelihood of heart failure by 40%. If you could modify three risk factors, you reduce the likelihood of heart failure by 60%. And if you could modify all four of these major risk factors, you reduce the risk of heart failure by 86%. And remember, once you develop heart failure and you're female, your risk of death from heart attack is 5-fold higher. Your risk of death from any cardiovascular disease is many-fold higher. So again, risk factor modification is very important. And it really leads to a new model for integrated care, because now we're thinking it's not just the electrophysiologist who is needed for optimal management of atrial fibrillation. You need the primary care physician, ideally a dietitian, ideally for the diabetes and endocrine specialist, for the stress reduction, maybe to discuss work habits, how many hours a week you work, a psychologist, a sleep physician for the sleep apnea, and an exercise physiologist to treat the metabolic syndrome. Now, in reality, no one really has 8 or 9 healthcare providers to do these different things. So it falls upon us, those of us who are here at the Gulf Heart Association, we have to assume all of these 9 roles ourselves, pretty much, to give the optimal treatment of atrial fibrillation. So what are the take-home messages? This atrial fibrillation is primarily a risk factor for systemic disease and a risk factor for stroke. And the first mission in AF patients is to anticoagulate to prevent stroke. Heart failure is a more common cause of death than stroke. And the risk factors include hypertension, diabetes, sleep apnea, cigarette smoking, obesity, alcohol use, and long working hours. Risk factor modification reduces the prevalence of atrial fibrillation, and the use of drug therapy or ablation to treat atrial fibrillation is also reduced. And finally, integrated AF care requires a multidisciplinary healthcare team, patient involvement and empowerment, educational guidance, and shared decision-making. Thank you very much.
Heterogeneous group of disorders, from obstructive sleep apnea to diabetes, hypertension, even long working hours. So, would you think that there is a common denominator for all these disorders or problems or risk factors, whatever we call it?
Well, I think atrial fibrillation is primarily a cardiovascular disease and vascular disease in the broadest sense. I think we haven't paid enough attention to the role of inflammation, and I think inflammation is really a common denominator for many of these problems. Obesity causes inflammation. Diabetes type 2 causes inflammation. High cholesterol causes inflammation. Sleep apnea causes inflammation. So I think that if we want to look for one common theme, probably inflammation crosses many of these areas. And unfortunately, we've tended to be very segmented and compartmentalized in our approach. Or we have just said, okay, the patients come in to a heart clinic, a cardiology clinic, we're going to just look at the rhythm. But the message here is let's look at what is behind the rhythm, what's led up to the rhythm disturbance.
Thank you. Short question and short answer, please.
Thank you. Yes, thank you very much for the presentation. Do you think that in the near future we should anticoagulate patients only based from the CHAD score, independence from the presence or not of the atrial fibrillation?
Yes, so the CHAD, there are many studies that show the CHAD score with or without atrial fibrillation, is very predictive of stroke. But what's coming down the road, the most powerful predictor of a stroke, far better than the CHA2DS2-VASc score, are the cardiac biomarkers. And if you look at simple biomarkers like the D-dimer level elevation, or troponin level elevation, or elevation of BNP, brain natriuretic peptide, if those are elevated in someone, even with a low CHA2DS2-VASc score, there's a very high likelihood of developing stroke, and not only of developing stroke, but also of developing myocardial infarction and heart failure.
Thank you, Prof, for your great talk. I just have a question about the striking data you just presented about the long working hours, 55 per week, which I'm sure probably more than 50% of people here, they are doing double that hours. So are we at risk of atrial fibrillation now, or?
I think everyone who is registered for this meeting is at risk for atrial fibrillation based on that long working hours. But I think actually that points that the long working hours are associated with stress, with release of catecholamines, and also that in turn is related to an increase in inflammatory markers as well.
So my question is, in this study, was there any cutoff of working hours recommendation, like per week, that should not be exceeded?
Well, yeah, it was a dose-response curve. It seemed to shoot up after 40 hours a week. And I don't know really, on a more serious note, whether it applies to anyone here, because I think, you know, we love what we do, and we're not really looking at the plots, and before we know it, 60 or 80 hours have gone by in the week. But I think this was not a study of health. This was not a study of healthcare workers. This was a study of all spectrums of the population.
Thank
So
you.
don't go away too worried.
Short question and short answer, please.
Thank you very much for your great talk. My question is, what is your opinion about the obesity paradox that it was very clear in the 4 clinical trials of the DOAC medications? There is a contradiction between the pathophysiology and the clinical. Thank you.
Yes, so there is an obesity paradox, and actually I presented a poster about the obesity paradox from the Garfield data at the European Society of Cardiology meeting in Barcelona last August. For reasons I certainly don't understand, I'd be very interested to talk with you at the break to see what your thoughts are. I don't really understand that. Even if you have obesity, even with a high rate of diabetes, for some reason, if you're really obese, you have a lower death rate. Part of that paradox can be explained because the obese patients are about 10 years younger than the other patients in the group, and so the younger age is a somewhat protective factor, but it doesn't really explain the obesity paradox. So I know I was talking to some of the fellows from Qatar Cardiology who are doing research projects, and I think I would recommend that some of you, if you want a great research project who really don't yet have an answer, you might do your research project on the obesity paradox.
One final question.
Last question is regarding the involvement of exercise physiologists and the treatment of atrial fibrillation risk factors, at least. So as that goes in terms of weight reduction and diet control, or are we targeting a certain heart rate like we do with patients post-MI and post-PCI and heart failure patients due to the heart rate variability in patients with atrial fibrillation?
Sure, great question. The exercise physiologist, just like the psychologist, that's more of a conceptual suggestion, and it really has to do with sort of a globalization of sitting on a couch and either watching television or just doing games on the iPhone and being very sedentary, and seeing that across the globe the rate of overweight and the rate of diabetes is increasing. So the conceptual thought there is get the exercise physiologist to prescribe a routine. The American Heart Association recommends at least 30 minutes of exercise per day for at least 6 days per week. And I'll tell you, in my clinical practice, I have a very busy clinical practice. I probably spend on average half of each session with the patient discussing ways to improve heart-healthy living, and much less time on the medications and that sort of thing. Because I think we live in a society that emphasizes medication and also mechanical interventions such as ablation, for example, for atrial fibrillation, and we need, I think, based on our new conceptual understanding of atrial fibrillation, to pay a lot more attention to the systemic factors, and a lot of those deal with converting someone over time to a heart-healthy lifestyle.
Thank you very much again. Now it's my pleasure to invite Professor Barbara Casati to update us on atrial fibrillation guidelines of the European Society of Cardiology. Barbara Casati is the leading scientist in Europe, and she's the president-elect of the European Society of Cardiology.
Thank you very much, Ali. Thank you, everybody, for inviting us, and also on behalf of the European Society of Cardiology, thank you for making us feel so welcome here. So I am not going to go through the guidelines as such, because they have been published in 2016, and therefore I assume you already have a good look at them. But I am really focusing on the update. That is what it is that has come out in the literature since 2016, and how might change our practice. So first of all, key consideration on atrial fibrillation, and I must say that I completely agree with the previous speakers, and looking at the literature, I come to the same conclusions. So you will see a little overlap in the slides as well. So key consideration is that atrial fibrillation is very common, and its prevalence with aging and the increased prevalence of risk factors, it's also increasing. So we are having a little bit of an epidemic here. So patients with atrial fibrillation normally are old and carry significant comorbidity, as well as a high risk of cardiovascular events. So I want to reiterate the conclusions of the previous speakers that we're looking here at high-risk patients, of which the atrial fibrillation is a biomarker. So then what we have learned is that atrial fibrillation is often clinically silent, and that is true particularly in the elderly and in patients with heart failure and history of stroke, or also high-risk patients. So we have a significant proportion here of patients who have atrial fibrillation, but it doesn't manifest clinically, and we don't quite know how to manage them. So we know the stroke and heart failure are more common in patients with atrial fibrillation, and they are responsible for a high rate of hospitalization every year, so there is a significant cost on the health system. And also we know that atrial fibrillation is associated with a twofold increase in the risk of all-cause mortality in women and in 1.5-fold in men. And so there is certainly a tangible risk, and that is also true for women who are often undertreated in terms of aggressive risk factor management. So where do I want to focus? I like to focus on this clinically silent problem, atrial fibrillation problem, because, as I said, we have evidence emerging of this that is opening up and challenging some of the assumptions that we have had so far on the issue of atrial fibrillation and the management. So how common is silent atrial fibrillation? Here are the results of ASSERT-2. These were not patients with an implanted pacemaker or defibrillator, but patients who have been implanted with a monitor and followed up over time. They selected a group of patients at high risk, high BNP, maybe an enlarged atrium and other risk factors such as aging, and followed them up for 18 months. And by the 18 months, if we consider episodes of subclinical atrial fibrillation or SCAF longer than 5 minutes, we see that by 18 months, about 35% of this group would have atrial fibrillation. So what do we do with a patient with 5 minutes of atrial fibrillation over 18 months? We do not know. And what they also looked was the impact, what is the sort of distribution of the duration of these episodes. And as you can see here, they are mostly short, and only in single figure we have silent atrial fibrillation that goes on for 24 hours or longer, which is similar to what we know in terms of clinically manifested atrial fibrillation. So, going back to the meaning of these episodes, as Dr. Goldhaber mentioned, ASSERT-1 shed some light on that. So here we are looking at 2,500 patients with older than 65 without a history of atrial fibrillation, but carrying a pacemaker or a defibrillator that allow the detection of these episodes of high atrial rate, as they call them, presumably mostly atrial fibrillation. So over 3 months of monitoring, 10% of them had subclinical atrial heart rate episodes greater than 190 beats per minute for at least 6 minutes, and over follow-up, only less than 50% of them developed clinical AF. So they may remain silent for quite a long time. And these episodes were associated to a 2.5-fold increase in the risk of thromboembolic events over a 2.5 years follow-up. So a risk that is, say, intermediate between patients in sinus rhythm and patients with clinically manifested atrial fibrillation. And you see, okay, so we have some issue here, some evidence here that may guide us. But the issue is really what Dr. Goldhaber was saying, and that is the lack of temporal relationship between these episodes and stroke. I have depicted them in a different way, but the message is the same. And that is that only about 15% of these patients had an episode of atrial fibrillation that preceded the thromboembolic event, but only just about 4 weeks or so. All the others happened after the thromboembolic event, or way before the thromboembolic event, that is, say, 6 months before was the median. So, can you actually see that 5 minutes of atrial fibrillation today may be the cause of stroke in 6 months' time? It's difficult for us to understand and really challenge the paradigm that we had before. And that is that atrial fibrillation causes a left atrial thrombus and the thrombus causes embolic stroke. So, essentially, the left atrial thrombus is there, the embolic stroke may well happen, but would it happen because of atrial fibrillation or because there is a substrate for both the formation of a left atrial thrombus and atrial fibrillation? And this really changes a little bit the way we should think and manage these patients. So this is the risk of patients with silent atrial fibrillation, and as I said before, it is somewhat intermediate if we look here between patients with atrial fibrillation and sinus rhythm. So you can see that it's about half of what we may expect for every level of CHADS score than that of atrial fibrillation. So why should that be? And that will come in a minute. So what do we do with these patients? We do not know, but the good news is that there are trials that have been designed, and particularly here there are two of them, Artesia and NOAA, that have recruited a relatively small number of patients, but they are hoping really to give us indication as to whether these patients will benefit from anticoagulation or whether they are just as well treated with aspirin. So the comparison here is with aspirin in both cases. So the other issues that is coming up and that can help us stratify these patients for risk and indication for anticoagulation is the AF burden, the duration of atrial fibrillation. So far, what we have decided as a community is that if you have 30 seconds or longer of atrial fibrillation, that is atrial fibrillation and you should be anticoagulated. Here there are data from the ASSERT-1 that was published last year. They show that there is, these episodes vary, and as I've shown you for the ASSERT-2, a certain proportion, in a certain proportion it's greater than 24 hours, but there are a lot of short episodes. And then if you look at the stroke in these patients, you can see that patients with no atrial fibrillation or very short atrial fibrillation episodes have more or less the same risk. And it's only those who have episodes longer than 24 hours that really are at higher risk of stroke. So this is a subgroup post-hoc analysis, so we can't, the study was not designed to answer this question, but it's giving us a clue that is coming out now in various directions. I mean, it is coming out in other studies, and is also coming out in clinical atrial fibrillation. So this is an example, and there are others, of substratification in ROCKET-IF. These are a trial of NOACs. When they looked at all-cause mortality by clinical IF type, in this case it's clinical IF, so we're really looking at persistent or paroxysmal, at baseline in ROCKET-IF. And you can see that the risk of stroke, this is the unadjusted, but this is the adjusted analysis, so it's still highly significant. So that the risk of stroke is actually lower in patients with paroxysmal atrial fibrillation versus persistent atrial fibrillation, and the trial of the bigger drug showed exactly the same. So we are now starting to think that maybe pattern and burden of atrial fibrillation should be used for the stratification, for the risk stratification of these patients. So what do the guidelines say now? They're taking, if you like, a cautious intermediate, in the absence of evidence, stance, and that is that if you see these episodes when you interrogate the pacemaker of your patients, then you should assess the eligibility for oral anticoagulation with the CHA2DS2-VASc score, and then really you should verify the presence of atrial fibrillation by ECG documentation. And so going back to the classical way of diagnosing IF, where we know where we are to some extent. So, and if you can document atrial fibrillation with the normal means, then you should consider oral anticoagulation. If you don't, then you can discuss this with the patients and take into account the patient preference. And I would say that the discussion with the patients, the contract between you and the patients in terms of what to do when there are gray area such as this, is actually a fundamental message of the 2016 atrial fibrillation guidelines. So as a result of that, though, I think it is recommended to interrogate pacemaker and ICD on a regular basis to detect these episodes and do further ECG monitoring when there is the suspicion of atrial fibrillation. So in summary here, subclinical atrial fibrillation is common and is associated with an increased risk of stroke that is intermediate. There is no temporal relationship between silent atrial fibrillation, subclinical atrial fibrillation and stroke. and whether anticoagulation is beneficial in these patients remains to be established and will come up in the few years. What it is important is that at the moment the guidelines do not currently take into account the pattern and duration of atrial fibrillation. However, the recent evidence suggests that AF burden may be important and more research will come on this side. So the other things I'd like to cover briefly is the stroke and heart failure. Because again here, in atrial fibrillation, because again here there is a little bit of evidence, new evidence coming out. So just to reiterate the 5 domains of atrial fibrillation management, it is so far, the evidence that we have so far is that really cardiovascular risk reduction and stroke prevention by aggressive risk factor treatment and anticoagulation is the thing that you should be doing to prevent major cardiovascular events and mortality in your atrial fibrillation patients. All the things you may fancy doing, such as atrial fibrillation and trying different way of doing it, you really only do it so far to improve symptoms. There is really no evidence that recovering sinus rhythm has an impact on mortality or stroke or other such important outcome. So why is that? You know, and for this reason, if the recommendations say that symptomatic paroxysmal, in the case of symptomatic paroxysmal atrial fibrillation, catheter ablation is recommended because we know it's more effective in maintaining sinus rhythm in these patients than antiarrhythmic drugs. But in the presence of heart failure, it is only really a two-way C recommendation, and that is a kind of consensus that says, well, you should consider it, particularly if the rate is fast and you want to decrease the risk of tachycardial myopathy. But, you know, there isn't really much evidence that you're doing a lot of good here. So, and that is despite the fact that if you have incident IF in the presence of left ventricular dysfunction, as shown here by the SOLVE trial, and as Dr. Goldhead has shown in a previous study, previously in the women's study, you have certainly a worsening of your prognosis, both in terms of increased hospitalization and increased all-cause mortality. And you would be forgiven to think that intuitively, therefore, restoration of sinus rhythm here must be a good thing, right? And as I said, there isn't much evidence that that is the case. So what it is that can lead to worsening of heart failure in the presence of IF? High ventricular rate is one of the things, and here is a study that was published last year that shows that if you have patients with dilated cardiomyopathy of no obvious cause, which they call tachycardia cardiomyopathy, then the management of these patients or follow-up compared to dilated cardiomyopathy and ischemic cardiomyopathy shows some significant recovery of the left ventricular ejection fraction that is greater than in the other two categories as shown here. So if you take this face value, looking at the increase in left ventricular ejection fraction, then you think, okay, well, then clearly there is a mandate here. But if you then sum this increase to what was the starting left ventricular ejection fraction of these three groups, this is what you see. And that is that this group still remain with a very low ejection fraction, even if you manage to effectively reduce the tachycardia. So, you know, and also this group in this study had a much lower, was treated not quite as satisfactory as the other two categories. So, how much is the rate versus the underlying undertreated cardiomyopathy that is causing both the reduced left ventricular ejection fraction and the atrial fibrillation? So, it's difficult from this data to conclude that it's the atrial fibrillation alone that is causing the cardiomyopathy. So this is also data showing that in patients with heart failure and atrial fibrillation, the beta blockers do not seem to have an impact on mortality, and therefore, again, it's going against the beneficial, the intrinsic beneficial effect of lowering rate. So also, if AF were a significant cause of heart failure, hospitalization, and death, a recovery of sinus rhythm should be beneficial. And even this has been disproved years ago now by the atrial fibrillation congestive heart failure trial. Here you can see the two groups divided by rhythm control and rate control. And rhythm control, were in a significant proportion in sinus rhythm. Yet this was not associated with any improvement in worsening of heart failure, stroke, or other outcomes. So it simply doesn't work. So what about ablation? Is ablation any better? So ablation causes, is associated, ablation of atrial fibrillation in patients with LV dysfunction with a mild increase in left atrial ejection fraction, but it is also, the ablation in these patients is also associated with a borderline raised rate of adverse event, a fairly high complication rate, and no difference in heart failure readmission in this study. So that's where the evidence we had when we went through the guidelines. But now these are two studies that have come out this year, at the end of last year. They challenge this a little bit. Here is the ATTACK multicentric randomized trial comparing amiodarone and catheter ablation in patients with heart failure. And you can see that there is a reduction in unplanned hospitalization rate in the ablation group and a small difference beneficial towards the ablation in left atrial ejection fraction. However, there has been question the way that the authors define the unplanned hospitalization rate, and if one includes all hospitalization rate, there isn't really much difference between the two groups. This has been the sensation of the years, and I'm down to my last slide now before the summary. So this is CASTLE-IF. So CASTLE-IF has recruited a small number of patients with heart failure carrying either CRT or an ICD, and they have undertaken aggressive ablation in these patients, followed them up. The mean follow-up amount, the median follow-up time is about 2.5 years. There's been a real struggle recruiting these patients, looking at this number. And it is seen in this case the patients who received ablation seem to have had an advantage in terms of cardiovascular mortality, global mortality, and hospitalization. This was presented at the ESC meeting in Barcelona, but has not yet been published. So we will see when it's published exactly which patients are these and why this study is so different in terms of outcome from those that preceded it. So in summary, what I would say is that to you as a take-home message is that patients with atrial fibrillation without heart failure, anticoagulation, and management of comorbidity, including aggressive management of risk factors, are the strategies of choice for preventing adverse cardiovascular outcomes in these patients. In patients with atrial fibrillation with or without heart failure, restoration of sinus rhythm with antiarrhythmic drugs has no impact on outcome, counterintuitive but true. And the rhythm control by ablation seems to be associated with a modest increase in left atrial ejection fraction that comes at the expense of significant rate of complications, and may reduce cardiovascular death, maybe in selected patients, and we're watching this space. So I'd like to leave you to see you all in Munich at the Congress of the European Society of Cardiology in 2018. I remind you of the guidelines, of the deadlines, and I thank you very much for your attention.
Thank you, Barbara, for this excellent
a very short time for discussion. Any questions? Well, I have just one comment and question. I don't feel comfortable with the term of subclinical atrial fibrillation, given the very high frequency of asymptomatic nature of atrial fibrillation and the temporal relations with the stroke, etc. What would you think?
Sorry, I can't hear you very well from here.
There is an echo here.
Yeah.
Is it a right term? I mean, the subclinical atrial fibrillation is a right term. I don't feel comfortable to use subclinical atrial fibrillation because, atrial fibrillation is mostly asymptomatic, and also there is a very wide range of temporal relations between atrial fibrillation and stroke. What would you think?
Well, I think that, I don't know whether you've seen you remember the data of the COMPASS trial. So the COMPASS trial was also presented in Barcelona, and these were patients at high risk that would be expected to have silent atrial fibrillation, according to ASSERT. They haven't measured silent atrial fibrillation, but they are expected to have it. And they have treated them with anticoagulation, alone or with aspirin. And in this particular patients with stable ischemic heart disease. And in this context, the low dose anticoagulation that was given to these patients reduced significantly the composite endpoint. And the composite endpoint reduction was driven exclusively by a reduction in ischemic stroke. So indirectly, you could say, therefore, that maybe we have prevented embolic stroke, ischemic stroke in these patients, and so atrial fibrillation is important. Yeah, silent atrial fibrillation is important. Or you can come to the conclusion, alternative, that atrial fibrillation is the biomarker, maybe when you see it or when you don't see it, but that if you have a patient at high risk, you have to factor in that this would be going on, that thrombus in the atria or other mechanisms are likely, and therefore anticoagulation could be given even without doing the monitoring and find out whether or not they have atrial fibrillation, although the monitoring may add to the stratification. This we don't know yet, but I think if I had to suggest an area of research, this would certainly be a good one.
All right. Once again, thank you very much. And we have to move on. The next speaker again is Dr. Goldhaber. He is going to speak on management of major bleeding associated with the direct anticoagulation.
Thank you. During this talk, I'm going to discuss preventing bleeding from occurring in the first place with the direct oral anticoagulants, how to approach a patient who is bleeding on a DOAC. I'll discuss replacement therapy with prothrombin complex concentrates, idarucizumab to reverse dabigatran, and andexanet to reverse rivaroxaban, apixaban, and edoxaban. It's important for us to identify and to treat modifiable bleeding risk factors such as hypertension and to shorten the duration of concomitant antiplatelet or non-steroidal anti-inflammatory drug therapy. Also, getting patients to reduce their use of alcohol and treating and normalizing anemic conditions are all steps we can take to minimize the bleeding risk of patients who we are planning to anticoagulate. I'll remind you that most of the direct oral anticoagulants work against clotting factor 10, but dabigatran is a direct thrombin inhibitor. It works against activated clotting factor 2, thrombin. The DOACs differ in their liver and kidney metabolism, and we can utilize these differences to select a DOAC for a particular patient based on that patient's kidney and liver function. For example, let's take dabigatran in the upper left-hand corner. This DOAC is the most that is metabolized by the kidney, 80%. So this is a great drug to give a patient with hepatic failure or some liver problems. You don't want to metabolize the anticoagulant with the liver. You would select the DOAC that mostly metabolizes by the kidney, and that would be dabigatran. At the other end of the spectrum, you take a patient with moderate or severe chronic kidney disease. We want to select the DOAC that is least metabolized by the kidney. And in the lower left-hand corner, you see that's apixaban, only about 25% metabolized by the kidney. In between these two extremes, we have rivaroxaban and edoxaban. So, when we approach a patient with bleeding from DOACs, there are certain basic rules. First of all, be sure to stop the anticoagulant. And sometimes a little chaos or confusion occurs, and we forget to write an order, stop the anticoagulant. We need to assess the severity of bleeding and obtain some very basic laboratory tests to guide us, including a complete blood count, prothrombin time, partial thromboplastin time, and creatinine. And if the patient can provide us with a reliable history, we want to ask an important question. When was the time the drug was last taken? And we want to use standard supportive measures that we would use for any patient who's bleeding. The administration of fluids, blood transfusion, and we want to activate trauma protocols if the patient's bleeding due to a trauma such as a high-speed car accident. Life-threatening bleeding, this would include intracranial hemorrhage, cardiac tamponade, any massive hemorrhage, any bleeding that causes hemodynamic instability, or situations where a patient will require emergent major surgery. And the question we have to ask and answer is whether surgery can be delayed until the anticoagulant effect wears off. And we have to ask, what is the balance between the risk of bleeding by delaying surgery versus the risk of restoring a baseline prothrombotic state by reversing the bleeding problem? Well, here's a very important concept. A lot of times we might prescribe antihypertensive medication or statins, and the patients don't actually take the medication that we have prescribed. We cannot assume that a patient has actually taken any DOAC anticoagulant just because we prescribed it. We really need to rely on some basic testing. That can be done fairly simply. For rivaroxaban, if the prothrombin time is normal, we can be almost certain that the patient was not really taking rivaroxaban or skipped the last couple of doses, and then for a normal prothrombin time with a rivaroxaban patient, you don't need to reverse rivaroxaban. That patient is bleeding for some reason not related to anticoagulant administration. Similarly, with apixaban, if the anti-10A level is normal, Well, if that patient is not bleeding because of apixaban, there's some other reason. We don't want to start to prescribe reversal agents for apixaban if that's not the cause of bleeding. For dabigatran, if the partial thromboplastin time is normal, or if the thrombin time is normal, that patient is not bleeding because of dabigatran. The patient may have been prescribed dabigatran, but certainly wasn't taking it before the bleeding problem began. And we can remember this algorithm, which is sometimes called the 4 R's, when we're trying to manage a DOAC patient who's bleeding. First, we want to step back and review the entire situation and try to figure out the last time the DOAC was taken, and we want to maintain vital organ perfusion and evaluate the patient for transfusion. Second, we want to remove the DOAC if possible. If the patient is fully conscious and the DOAC was recently taken, we can try gastric lavage or oral charcoal. And for a dabigatran patient, we can theoretically do emergency hemodialysis. I think what we use the most often is the 3rd R. That's repair. Because most of the GI bleeding is going to be, most of the bleeding from NOACs is going to be gastrointestinal bleeding. And usually the anticoagulant has uncovered an ulcer or some other anatomical problem in the gastrointestinal tract, and we need to call our friendly endoscopist to do emergency endoscopy and to freeze or buzz or do whatever is necessary endoscopically to treat the bleeding. And if that's not possible, we have to take the patient to the operating room. And then the 4th R, we get into the reversal agents, either prothrombin complex concentrates, sometimes we'll be administering platelets, or for dabigatran patients, giving daratumumab. So let's talk about prothrombin complex concentrates. They contain factors 2, 7, 9, 10, protein C, and protein S. They're used to reverse bleeding from warfarin. There is a possible rebound thrombosis from using the prothrombin complex concentrates. We have to keep that in mind. And the dose that we usually use to reverse bleeding from rivaroxaban, apixaban, or edoxaban is 50 units per kilogram. The indications for the reversal agents are life-threatening bleeding, the need for emergency surgery, or delayed clearance of the drug and continued bleeding. But we don't want to use the reversal agents if surgery can be delayed, because friend is our time. These DOACs are generally very short-acting with short half-lives. We don't want to use the reversal agents if we have an abnormal coagulation test but no clinical bleeding. And we don't want to use the reversal agents if the bleeding can be successfully managed with routine supportive care. Here are our 2 antidotes. The daratumumab, which was approved by our Food and Drug Administration in October 2015. It's an antibody to dabigatran. And the other reversal agent, which will be reviewed by our Food and Drug Administration next month in February, and the FDA will decide whether to approve andexanet. This is not an antibody, but it's a decoy agent. It reverses all the anti-10A DOACs, rivaroxaban, apixaban, and edoxaban. Here you see the structural similarity between the dabigatran antibody on the left and thrombin on the right. The antibody mimics the structural features of thrombin. And ordinarily, when we administer dabigatran, it binds thrombin. And by binding thrombin, we get successful anticoagulation. But if we get bleeding, and we want to immediately, within seconds or minutes, reverse the effect of dabigatran, we can administer idarucizumab, which binds to dabigatran 350 times more strongly than dabigatran binds to thrombin. Once idarucizumab binds to dabigatran, the thrombin is now liberated, and the thrombin can do what thrombin is supposed to do. That is, to cause some coagulation and stop the bleeding. Here you see the pivotal trial of reverse AD for idarucizumab. The dose of idarucizumab is 2 separate infusions of 2.5 grams given intravenously as quickly as possible. And what we see in this pivotal study is immediately after giving the idarucizumab infusion, the thrombin time, which started elevated due to the dabigatran, it comes back immediately to the normal range. Now, andexanet is different. Andexanet is a decoy. You can see it has some structural similarities to activated clotting factor 10. Andexanet acts as a factor 10A decoy. It really reverses the anticoagulant effects of the factor 10A inhibitors. It's been purposefully designed so that it retains, as you can see on the right-hand side of the slide, a high affinity for the 10A binding site. The catalytic domain activity is eliminated to prevent thrombin generation. The GLA domain is removed to prevent the anticoagulant effect. And the N-terminal residues are retained to reduce immunogenicity. And here we have an example of rivaroxaban binding to the prothrombinase complex on the left-hand side of the slide. And when the prothrombin complex is bound and inhibited, you cannot have normal, you just have a lot of bleeding, you can't have normal coagulation. So then andexanet comes along, this is andexanet, and rivaroxaban is really attracted to andexanet because it's a strong decoy. And rivaroxaban abandons the prothrombinase complex, which is active again. Rivaroxaban binds to this decoy. The decoy is inert. And now you have an activated prothrombin complex that's very happy because the prothrombin is converted to thrombin, and the thrombin will stop the bleeding. There are studies with andexanet showing that you need to use different doses depending whether you're binding apixaban or rivaroxaban. Here you see the pivotal paper of andexanet for acute major bleeding associated with the factor 10A inhibitors. That was an interim analysis of 67 bleeding patients. And you see that the hemostatic efficacy at 12 hours after administration of andexanet was very high, judged to be between 75% and 100% efficacious, regardless of which anti-10A agent was used, regardless of gender, regardless of whether the bleeding was gastrointestinal or intracranial, regardless of age. Now, I'll just tell you for the future, and we'll probably discuss this at the Gulf Heart Association meeting next year, there's another challenger on the block, and that's this small molecule siraparentab, which supposedly can stop bleeding from any anticoagulant that's ever been created. We don't really understand its mechanism, and the drug, to a large extent, is shrouded in secrecy, but nevertheless is considered very appealing from what we know about it so far. Now, here's an important point. Once a patient has had a major life-threatening bleed, the last thing in the world we want to do intuitively is to resume anticoagulation, because the patient, we've just treated the patient for major GI bleeding or major intracranial bleeding. We're not really excited about resuming anticoagulation after a major bleed, but it's very important that we do so. Here you see data showing what happens if we don't resume the anticoagulant. Without resuming the anticoagulant, is shown in red, the survival rate decreases, so more patients die. If you don't resume the anticoagulant after a major bleed, more patients develop in panel B heart attacks and strokes, is shown in red. And you would think that if you don't restart the anticoagulant, at least you're going to be a big winner and have much less major bleeding in the future. But in fact, the number of major hemorrhagic events is the same whether you start or don't restart the anticoagulant. So in order to reduce mortality, in order to reduce heart attack and stroke, we really have to bite our teeth, bear down, and resume the anticoagulant as quickly as possible. Even though the right-hand side of our brain is saying we can't do that, the left-hand side of our brain is saying we must do that based on the data. So in conclusion, we have to do in the bleeding patient a careful initial assessment in order to stabilize the patient, and we have to decide whether to use our arsenal of reversal agents in these patients. And these would include the Vigatran, reversal by the antibody adagrasib, and for the moment, reversing or replacing the components of apixaban, rivaroxaban, and endoxiban bleeding with the prothrombin complex concentrate. These patients are tricky. They require continued assessment, continued monitoring with serial evaluation and supportive care. Thank you very much.
Thank you for this excellent talk. For the sake of time, to be finished on time, we have to move on.
Okay, so next we have Dr. Philip Saul, who's Professor of Pediatrics and Executive Vice President at Children's Hospital of West Virginia University. He's going to be talking about cardiac channelopathies and arrhythmogenic cardiomyopathies.
As soon as I get my slides. There we go. Good afternoon. It's a pleasure to be back again. And I was mentioned this morning that I had been in this hotel about 10 years ago. I found some pictures from the inside of the hotel. This looks about the same, even though it's been completely redone. This is from 2005. For those of you who haven't been in Doha and have a little bit of time, there are a lot of interesting things to do around town. I wouldn't advise going to the Cath Lab for fun, but it can be fun for some of us anyway. And here are some of the people I've worked with over the years. This is Dr. Vidal, who you have seen, and Syed Mahmoud, who runs the EP lab, and it's been a pleasure working here over the years. So what I'm going to do today is start with a case study, talk a little bit about long QT syndrome, particularly as a paradigm for genetic diseases. So I'm going to spend a kind of an important amount of time on long QT syndrome, looking at the genetics, phenotype correlation, and a little tiny bit about genetically based therapy. Talk just a tiny bit about one other channelopathy, just for examples of important points, and very little about cardiomyopathies with arrhythmias that are structural, and finally the role of genetic testing and a little bit about where we're going in the future. So this is a case that I had at Children's Hospital in Boston a number of years ago, 8-year-old girl who had a history of seizures, came into the emergency room, had new onset of syncope, and she got this EKG. And some of you may have looked at the EKG and noticed something wrong. They didn't in the emergency room. And they gave her a Holter monitor. She brought it back the next day. Fortunately, she was alive when she brought it back. And here's what was on that Holter monitor. And it's a little hard to tell at this scale, but basically this is Torsade. And when we look back at the ECG and took another look, the next day we saw that her corrected QT was indeed 590 milliseconds, which obviously is long. And this girl had congenital long QT syndrome, which one of the presentations is seizure disorder. Probably her seizures were had been due to her long QT syndrome. So this is really in the point of review here. It's a genetic disorder. We used to think it was quite rare, and now know that about 1 in 2,500 people actually have the genetic disease. The ECG evidence that you would think would always be long QT, but it's actually only about 65% of the time that the QT is long, and it's been defined as 450 milliseconds in males, 460 in females. There are a lot of normal people with QTCs longer than that. I'll come back to that in a minute. The hallmark arrhythmia is the one I showed you, and the primary presenting symptom is usually syncope, and unfortunately it can be sudden death. It's often with physical or emotional stress, which we'll talk about a little more. The family history may be positive for sudden death, or long QT syndrome, or syncope, but syncope is very common, not in long QT syndrome. And of course it does cause sudden death in children, young adults, and occasionally in older people. This is one of the original reports. This is Romano and Ward's report from 1964, I think. Is that right? Yes, 1964. It's actually not the very first report, but it is the syndrome that most of us think about, the autosomal dominant report. You can see they showed both the long QT and the Torsade. And here's actually the first report from Jarell and Longa-Nielsen in 1957, where they described patients who were deaf and had a high incidence of sudden death. And I'm going to come back to this because it's a very interesting part of the story. So the rationale for treatment comes really from this data that Peter Schwartz put together from the International Registry in 1985, very early in the registry. And basically it showed that if untreated, there's 20% mortality in the first year and up to 50% in the first 10 years. So without therapy, if you presented with a symptom, these are all probates, you're presented with a symptom, it's a very lethal disease. And fairly quickly, because of the sensitivity of the disease to sudden sounds and emotional stress, people began to use beta blockers. And beta blockers, we now know if you're very good with your beta blocker therapy, they're probably 95 to 98% effective. What Peter found here was that it reduced mortality dramatically and made the 10 to 15 year event rate less than 10%. So if you take them well, they seem to work very well. So pre-genetics, really the way, this was sort of a voodoo disease. There was a lot of argument. Was it autonomic imbalance? Was it a genetic problem? Something wrong with her? There was even a paper from Great Britain where a group had auto-transplanted a patient with severe long QT, and they didn't get better. They took the heart out, put it back in, and said, well, it must not be autonomic, but obviously that patient was very sick. So the treatment really was to avoid QT prolonging drugs, which we knew a little bit about, be very good with your beta blockers. Pacemakers alone pretty much fell out when the defibrillators came out, and then occasionally less sympathetic stellate ganglionectomy. And to some degree, this is still the mainstays of therapy. And in terms of diagnosis, we really had to rely on the clinical features. So you look at the, let's go back. There we go. Look at the QTC. If it was very long, greater than 180, you got a lot of points. If it was a little shorter, you got fewer points. If you had T-wave alternans, if you had torsade, if you had syncope with stress, and even deafness came in. And then if you had a score greater than 4, that was a high risk, and you were likely to have the disease, or high probability of having the disease. If it was less than 2, not so high. The problem with that is so many people have a QTC in the 470, 480 range that are perfectly normal. And so if you just do the math, it's about 500,000 people in the US would have at least one episode of syncope and a QTC of about 480, but there are only 100,000 people with low QT syndrome. So not very sensitive, but this was what we had prior to genetics. And then in 1991, Mark Keating from the University of Utah had a very large family in Salt Lake City. There are a number of Mormon families that are extremely large, and they had one huge family to work with where they could do linkage testing, and they came up with a genetic link. Now, it turned out it wasn't quite the HRBREST1 gene, it was the human Ether-a-go-go gene, which was right next to it, but nonetheless, this sort of changed the paradigm completely. And the very cool thing was when they identified it as the human Ether-a-go-go gene, which we call HERG. Many of you have heard of that. This was now called LongQT2. HERG is actually a gene that codes for a protein that controls the potassium channel, the inwardly rectifying, rapidly rectifying potassium channel, that is involved in repolarization. So it was really an amazing finding at the time. And not only was there a gene found, but that gene coded for a protein that prolongs repolarization and made sense. So it was a really extremely important benchmark in the field. And this was born in the cardiac ion channelopathy, which could be defined just as an inherited disorder caused by a mutation in a gene that encodes for an ion channel protein that results in an abnormal heart rhythm, and for most of these abnormal repolarization. And I'm going to talk about that we now have potassium channels, sodium channels, and calcium channels that are all involved in cardiac ion channelopathies. So now I'm going to use LongQT syndrome as a paradigm, just like I said. We've got a lot of them now. There are probably more than 20 of these. One of Dr. Hayes' colleagues, Mike Ackerman, has been looking at undiagnosed cases now with whole exome and whole genome sequencing to try and get the little bits of them. But most of these patients are in the LongQT 1, 2, and 3 categories, which are 2 of them are potassium channel and 1 a sodium channel defect. The other ones are all relatively small, and eventually we'll probably figure out 80 to 90+ % of these, but right now it's 75 to 80% of clinically diagnosed patients we can come up with the gene that's responsible in that particular patient. And again, as I mentioned, all of these, I guess the pointer doesn't work on that, all of these end up coding for a protein that's involved in repolarization. So it's a very tiny package when you put together the known identified genetic abnormalities along QT syndrome. And that data has been very useful. It's turned out that it's helped a lot with the phenotype as well. Sylvia Priori took the LongQT registry group in 2005, published a fair bit of data looking at different features of the disease. This is cumulative cardiac event-free survival versus the type of defect, LQT 1, 2, or 3. And you can see that for LQT 2 and 3, 1 potassium, 1 sodium channel, the event rate is higher than for LQT 1. And this is a very long follow-up of time over multiple years for the presenting, for the probates presenting, or ages, I should say. There are also gene-specific triggers. It turns out that LQT1 is the one that's most likely to be triggered by exercise, LQT2 by emotional stress. This is one when you jump in the pool. Cold water, more likely to have an event. And actually, the sodium channel defect, LQT3, is a little more likely to occur at rest. So learned a lot about trying to figure out kind of some of the magical thinking parts of the disease. What was all this due to? It turned out to be related actually to the underlying genetics. One of the most fascinating things is that despite the fact that we still call it LongQT syndrome, is that 30% of the patients don't have a LongQT. So here is the LongQT group down here, and here is normal, and you can see there's an enormous overlap between about 430 and 470 to 480 milliseconds. Once you get to 480, there's very little overlap. Most of the patients have long QT syndrome, and if you get below 400, nobody does, but there's a wide range of overlap there. And it is true that the longer the QT, the more serious the disease, the higher the risk, but does not completely eliminate risk just because you have a short QT, and vice versa. And then Sylvia was able to take a wide variety of clinical data and the genetic data and put it all together in an algorithm and come up with a high risk, an intermediate risk, and a low risk group. And I'm not going to go through this because it's not really, the important point I want to make is that putting together the clinical and the genetic data ends up more predictive than either of those alone. The other thing that came out is Steve Compton, when he was a late fellow in Utah, again with Mark Keating down here, who was the lead for the genetics part of the discovery, found that you could take certain patients and raise their potassium. And this makes sense when you think about that the defects block potassium channels, so you could actually raise the potassium and in some cases make it way better. So if you use spironolactone and potassium, you can take particularly patients with long QT2 and turn them from an EKG like this to a normal EKG. And this is a little bit hard to do in the long run. It's hard to keep people's potassium up, even on spironolactone and potassium, but I have used this selectively in a few patients over the years, and it can be extremely effective. And there are other therapies coming along. Like Corindil is not available in the US. I'm not sure if it's available in the Gulf region, but it is in some countries in Europe, and it actually helps with long QT1. But importantly, there are a couple of the specific genetic defects for long QT3, which is the sodium channel defect SCN5A, in which flecainide is basically a cure. Because the abnormality here is that the sodium channel is hyperactive. It stays open too long, and that prolongs repolarization. And mixilotine works for many of these, but flecainide is very specific. And if you have a patient with that, your local electrophysiologist ought to be able to tell you if they're ones that will respond to flecainide. But as long as the patient takes it, it's virtually a cure for the disease. The other interesting thing about long QT syndrome is another kind of voodoo abnormality or disease was sudden infant death syndrome. About half of those voodoo cases were cured just by getting babies to sleep on their back. In the US we call it the back to sleep therapy or back to sleep program. And that reduced the rate of SIDS from about 1 per thousand down to a half per thousand. But then it turns out that in addition, 10 to 15% of these patients in multiple studies have long QT syndrome. This just makes enormous sense. There was a big argument for a long time. Was it a respiratory disease? Was it a cardiac disease? Well, of course, if you have sudden death, it makes sense that some of them have a cardiac disease that causes sudden death. And these are obviously the severe cases because they die in infancy. So it's not as clear that that management would be as effective as in adults, but it probably would be pretty good. And if you wanted to screen anybody for EKGs, there's a lot of data that would suggest that this is the group to screen to identify long QT syndrome in infants. I'm not going to go into that data right now. Now this is a great part of the story. So I mentioned Jervell Lange-Nielsen was thought to be an autosomal recessive disorder that caused deafness and long QT syndrome. And this was a case that I was involved in. The proband is right down here, was a baby that was born with deafness. And the pediatric cardiologist saw the baby. It's an autosomal recessive disorder, but they said to the mother, mother and father, you should get EKGs. It's probably a good idea to get an EKG. They never did. They treated the baby's fine, the mother died. The mother's blood and the baby's blood were sent off to Mark Keating's lab. And what they found was that this is a homozygote. So the proband here had 2 copies of the same gene. Most of these families have consanguinity, so the parents are relatives, and that was the case in this case, and they have 2 copies of the same gene, but neither family knew they had it because these were mild copies of the mild forms of the disease in both families, but you put them together and you get both deafness and long QT syndrome. And I'm going to come back to this concept in a minute. Most of these are long QT1 with long QT1. A number of them have other varieties. You can see LQT5 is the other half of LQT1, and then you can even get LQT2, LQT3, and these are all severe forms of long QT syndrome with very high mortality, even treated, but certainly untreated. Some of them have deafness and some of them don't. So a very cool finding that something that was thought to be a recessive disease was actually a homozygous dominant. And what this brings up is this family, which again is from Sylvia Priori, and here was the proband in this case. This patient died, and EKG was gotten on the sibling, and the sibling had a long QT. Nobody else in the family had a long QT, and really nobody else had died in this family. There was no history of sudden death. They did the molecular diagnosis on the other side, and you can see a whole lot of people in the family have genetic long QT syndrome, but only one had clinical long QT syndrome. So this is variable penetrance. This is true with every genetic disease, just about every genetic disease. There are very few that have full penetrance. But what it means is that it's very hard to figure out who is important to look at, and if you get a whole family with long QT syndrome, do you treat them all, do you not treat them all? Now, we're getting to some of the future parts of the talk. This is a single family, two families actually, put together because they had the exact same genetic defect, one from the Netherlands and one that Mike Ackerman had at the Mayo Clinic. And what they looked at was the genetic material that's associated with the primary gene. So the primary gene has the defect. And then they looked at things in the genetic material nearby in the untranslated region, which are called single nucleotide polymorphisms. And what those SNPs do in you and me is they give some of you people brown eyes and some blue eyes, and some of us get bald early and some don't. Some have gray hair early and some don't. These SNPs are what make us different. They're the small differences in our genetic code that don't make any difference, except it makes us a little different from somewhere else. Many of us learned in medical school that some people given succinylcholine will be paralyzed for an hour, whereas most people are only paralyzed for a few minutes. And again, that's from these small single nucleotide polymorphisms, or SNPs they're called. So they looked at the SNPs in these two families, and what they found was they could segregate the family members by QTC and the SNPs. I'm not going to go into all the details because it doesn't matter. The important point is that by just looking at 3 SNPs in the untranslated regions surrounding the KCNQ1 gene, they could segregate the family into Minnie, the group here of 5 who had very low QTC, probably no risk, and this group of 9 who has very high QTC and probably very high risk. This is the future of genetic testing. This is the part that we're just too stupid to know about right now because it's very complicated, but it's the thing that's going to change how we interpret genetic tests in the future. As I mentioned, I'm going to talk just a little bit about the many cardiac channelopathies, but I just want to talk about Brugada for one moment to make one point. So Brugada syndrome, another kind of voodoo disease. We look for these changes, these early repolarization changes in the right chest, V1, V2, a little bit. Here you can see a more kind of intense presentation, but we know there are a lot of people who have these that there's just nothing wrong with. Some of them may even have Brugada, but they never present with problems. So Brugada, a very complicated disease. Now, what we found, we don't by any means have as good a genetic understanding of Brugada as we do with 1QT, but you can see that one of the Brugada genes, ERS1, is just SCN5A. That's the same gene that causes long QT syndrome. And we'll say, well, how did early repolarization and long repolarization come into the same gene? And many of these others are related as well. And here's just this cool part of the story. So if you have an SCN5A defect that causes a gain of function, so if it makes the sodium channel stay open longer, it prolongs repolarization. If it causes a loss of function, it causes early repolarization in Brugada. This is just how complicated the genetics are going to be, but how interesting it's going to be when we get smarter and understand it all. What about genetic testing? So this one's pretty obvious. 2-month-old sibling of a patient who died of sudden infant death, had a QTC of 600. We want to know the genetic abnormality here so we can test the family and do other things. What about this one? Many of you see him in your clinic. Young person, 16-year-old, 22-year-old, comes in, gets an EKG for some reason, the QTC is 470, or even more. We know 35% of women and men together will faint by the time they're 25 years of age. So they come in with syncope, get an EKG, and the QTC is 470. So you're going to worry about them a lot, but most of them probably don't have long QT syndrome. So who do you test?
These are the standard class 1. Definitely everybody would test. 2A, most people would. 2B, maybe wouldn't. In class 3, not a good idea. And then the levels of evidence. So Mike Ackerman and Sylvia Perori led this group from 2011. I just looked again while I was sitting down there. I can't find an updated set of guidelines for this, so I don't think I missed it. And what they came up with was basically, it's really pretty much what you would figure from common sense. If you have a family member of a diagnosed index case, they should be tested because it's easy. And I showed you how you can have that variable penetrance you don't know from the clinical condition. It's relatively inexpensive to test family members once one person is diagnosed genetically. And then if you have a high clinical suspicion of long QT syndrome, that's a reason to test as well. So where does that high clinical suspicion come in? That varies a little bit by the practitioner, but certainly at 480 and syncope, that's high. It's going to be similar for Brugada, family members after index case identified. It's just 2A for high clinical suspicion. Going to be true for catecholaminergic polymorphic VT. It's basically, again, common sense. Test the family members of known diagnosed patients. Test patients with high clinical suspicion of the disease. Now, why don't we test everybody? We will. In 10 years, I'm 100% sure there will not be an infant born in the developed world that doesn't get a full human genome done. The problem is that right now we're too stupid to interpret it, and so you get way more variants of unknown significance than you will actual defects. And here it just shows some of the data for CPVT. You're going to get 20 variants of unknown significance to every 1 real. At long QT, it's about 19, and for Brugada, it's about 10 to 1. So if you started just testing people willy-nilly, you're going to get a lot of stuff, and you're going to put a lot of people on beta blockers, and you're going to worry a lot of families, and you're not going to know what to do with it. So we try to test those with either high clinical suspicion or known family diagnosis. So to summarize this part, cardiac channelopathies underlie most of the sudden arrhythmic death syndromes that we know about. We can identify between 30 and 80% of these cases, depending on which channelopathy it is. There are many genotype-phenotype correlations that are very useful, and there are specific channel and DNA defects that can help guide therapy. And then watch out for variants of unknown significance. I just got about 2 more minutes here. I'm not going to talk about the cardiomyopathies, even though they're very interesting. What I want to talk about is the little bit we know about whole exome and eventually whole genome sequencing. So the exome, this is a study of about 650 cases that I'll show you the data from. But basically, when you look at the exome, you're looking at all the known coding for the proteins. The 180,000 proteins in our body, there are about 180,000 exomes. It contains most of the disease-causing mutations, about 85%, but it's only about 2% of the genome. So there's a whole lot of genome out there that maybe isn't useful or maybe is useful, but we don't know how to interpret it. We can do it with massive next-generation sequencing using parallel processing. And basically, here's why we don't test everybody. For each person you test, you're going to get 200 to 400,000 SNPs that are different than the average. But there's only one deleterious mutation if you're looking for a specific disease. Sometimes somebody has 2 diseases, but not that often. And so you've got to be able to sort through that. You can do it, you can get it down to a couple of hundred, so you can get a focus report about the disease and an expanded report, and perhaps, if you're careful, you can interpret that correctly. But it's a very hard paradigm. But what has happened with these 250 cases that were sent to Baylor, these were all patients who had been tested who had clear genetic syndromes. Something was wrong with them that was not normal, but it couldn't be identified with standard genetic testing. And what they were able to do was identify the actual mutant in about 25% of cases. We're up to about 40% now. We're doing better. It's still not for everybody, but it is an option out there. And basically, these were unselected patients. As I mentioned, 25 to 40% positive. In the US, at least, it's usually covered by insurance because it's way cheaper than all the testing we do on these patients. I mentioned most of those patients had prior genetic testing. It is very important for the family, and in some cases, you find a protein, you find a gene that codes for a protein where we have a treatment for it. You can give the missing link and actually treat the disease. So, I'll say the future isn't quite here, but it's coming fast. The field of genomics is developing, I think, much, much faster than anybody recognized. And as my prediction is, within 5 to 10 years, we'll all get our genomics done, if you haven't sent it off already, to 23andMe or somewhere else, and we'll actually know what to do with that data. Thank you for your attention, and
thank you, Dr. Saul, for that very great overview of channelopathies and genetic testing. Unfortunately, we're running short on time, so I think we'll just move on with the second session and keep the questions till the end. So next we have Dr. David Hayes, who's Medical Director of the Mayo Clinic Care Network, as well as past President of the Heart Rhythm Society, and he'll be talking about external electromagnetic interference and when it should be a concern for patients with implantable devices.
Thank you very much, Mr. Chairman, ladies and gentlemen. While my slides are coming up, I'll make the comment that I've enjoyed the talks in the session very much. The majority of them have been about rhythm disturbances, so this one could be an extension of that if any of your patients with atrial fibrillation and heart failure or your patients with channelopathies have ended up with the device. However, if any of you in your practices deal with device patients at any time, you will come up against questions about management of patients and electromagnetic or electromechanical interference. It's been a long-standing interest of mine. Have done a fair amount of clinical research from even early in my career, some of it which I think had an impact, some of which was probably somewhat nonsensical, but looking at the effect of various items, the potential for electromagnetic interference on patients with CIEDs. And if you're not familiar with that acronym for cardiac implantable electronic devices, so it takes into account pacemakers, defibrillators, CRT, and even loop recorders. If we talk about when are we really concerned, if you cut to the chase, the question about electromagnetic interference is if it is anything that causes the patient to be symptomatic, or if it has the potential to create a life-threatening situation for the patient. That's when you're concerned, because there are many types of electromagnetic interference that can cause single beat inhibition of a device, very transient problems. It's just not a concern. So the potential clinical effects of EMI are shown here. In pacemakers, you could have failure to deliver anti-bradycardia pacing. In defibrillators, you could have failure to deliver therapies. You could have inappropriate delivery of therapies. You could reprogram the device. And if the current was carried directly down the conductor coil, you could have damage either to the device and completely blow out the circuitry, or you can have damage at the lead myocardial interface, actually causing a burn of the myocardium. This somewhat basic slide, I point out so that you understand that when it comes to the frequency spectrum for cardiac events, that there is an overlap between a typical T-wave, PVC, and R-wave. So it explains why a device will sometimes mistake one intracardiac event for another. But the real point I want to make is that if you look over here with the orange arrow, that many of the current devices in this environment of ever-increasing wireless gadgets fall into that frequency spectrum. So that every type of new wireless device that comes out where a patient's going to have direct contact really needs to be tested to see if it could have an adverse impact on device patients. I generally think about interference both from the hospital environment and the non-hospital environment. And there's no question that the hospital environment is where most of those sources exist. That's where the patient's at the most danger. They're listed here, but there are two things where you are most likely to get questions about management or concerns about adverse clinical events. That has to do with electrocautery cardioversion, defibrillation, and ever increasing with magnetic resonance imaging. So I'll spend a little bit more time on those two topics. So again, in the hospital environment, if you know the patient's going to be exposed to something where there's potential for electromagnetic interference, as long as you know the potential sources, you know how the patient was programmed prior to exposure to that source. If ICDs, if high voltage devices, they need to be reprogrammed to monitor only. turn off the therapies, but obviously the patient has to be placed on external monitoring with appropriate personnel present to manage the patient should they have a ventricular tachyarrhythmia. And then after exposure, rechecking the patient, restoring programming, turning therapies back on, and making sure that there hasn't been any change in how the patient was managed. This is a consensus statement from the Heart Rhythm Society and the American Society of Anesthesiology. It's a little older now. I believe it was finally published in 2011. But this is an excellent document for any of you that have device patients that are going to surgery and will be potentially have electrocautery applied. This is really a very exhaustive, detailed consensus document how to manage those patients. And I'll refer to this again in a few minutes. Basically, my somewhat simplistic approach is you have a patient that's going to surgery with an implantable device. Again, document the program parameters. You need to determine whether or not they are dependent on the device for bradycardia support. That's a crucial issue. If they're not pacemaker dependent, then for a pacemaker, it's pretty simple. You really don't have to do anything, but oftentimes we will turn off a rate adaptive sensor because that can cause confusion in the operating room because they can be activated by electrocautery. If you have a high voltage device, an ICD or a CRTD, then the patient needs to be monitored, tachytherapy is turned off, and monitored closely throughout the duration of the procedure. If you have a pacemaker dependent patient, for the pacemaker patient, you simply program them to an asynchronous mode. For the high voltage patient, you program them to an equivalent of an asynchronous mode, and again, turn off the therapies and external monitoring. Post-operatively, patients need to be reinterrogated and all of the therapies returned to their preoperative state. I won't go through this in detail. I put it up as an example from that consensus document that I previously referenced. This is one of the many tables that's included in that. And here they particularly make the point that if your patient's undergoing surgical procedure, the importance of using bipolar electrosurgery or electrocautery as opposed to monopolar. But again, they go through all of the potential risks, and if you're dealing with these patients, this is an excellent source. For many years, as we had patients going for any type of surgery where electrocautery would be involved. So even simple dermatologic cases or endoscopic cases, we would routinely see those patients before and after. We've now learned from many studies, this being a smaller one actually, from 2016, that depending on where that surgery is, you may not need to be too concerned. Basically, if the surgery is below the waist, there's very little chance that there'd be interference with the device. It's when the surgery is in the thorax or the head and neck that there's really a higher chance of interference and reprogramming. Sometimes problems occur despite our best efforts. We have a cardioversion unit where it's staffed by permanent personnel who do nothing but cardioversion day in and day out. We have very specific protocols for our device patients. Here's a patient that was handled according to protocol, atrial fibrillation, a dual chamber pacemaker. Prior to the cardioversion was programmed to VVI mode, ventricular pacing, so that we could easily see the underlying rhythm. Patient had cardioversion, as we always do it for a device patient, and as you can see from this tracing, we were successful in that normal sinus rhythm was restored, but unsuccessful in that we now had no effective capture. You have ventricular pacing spikes without any capture whatsoever, and it turns out we were able to restore capture in the ventricular lead, but we had actually damaged the circuitry and had to eventually replace the pulse generator. So sometimes, again, best efforts, problems occur. Now, an issue that is of significant interest is that of when can you image a patient with a standard device that is not a conditionally safe MRI device, but a standard device, and have them undergo MRI imaging. As we all know, MRI is the favorite modality for many types of issues, and obviously avoids radiation. But we know there are problems, and from this slide, you can see that the hazards include several things, but the most important ones, if you go down that list on the left-hand side of the slide, is device interactions, therapy delivery, device reset, or damage, or unintended cardiac stimulation. Here's an example of that. This is from an ancient study that I did with one of my colleagues, I think when we got our first MRI, and I really don't even remember if that was a 0.5 or a 1.0 Tesla device. But this was a canine study. And let me draw your attention to panel B. And what we did was to implant the dogs with a device. And you can see that at the beginning, we placed the dog into the gantry, and it's a huge magnet, so that causes asynchronous pacing. But then when it says RF turned on, the RF frequency of the MRI was pulsing at 300 milliseconds, at 300 milliseconds, 200 milliseconds, which somehow in the dog was able to couple with the device and pace the dog at 300 beats per minute. At 300 beats per minute, there was hemodynamic collapse, as you might imagine, and this became one of the reasons that MRI was prohibited in device patients. And this has been seen in patients. There have been a number of deaths that have been documented from patients who got an MRI with a device in place. With that said, there have now been several large registries of doing MRIs in patients with standard devices. The MagnaSafe registry on the left, the last publication I was able to find, there were about 1,500 patients. Multi-center study, protocolized, but the bottom line was none of these patients had any significant adverse effects. At the Mayo Clinic, we've been doing this under protocol, initially an IRB protocol, since 2008. I'm guessing at the current number, I know that it's greater than 1,200, I think it's closer to 1,500 patients at this point in time, who had standard devices that underwent MRI imaging. Now, in the beginning, we limited that to pacemakers. We've now extended that to ICDs and CRTs, initially non-thoracic. We've now extended it to thoracic. And we've done some dependent patients as well. And the bottom line is we've not seen any damage or any significant clinical issues if you carefully follow the protocol and have the right personnel present. The one caveat is that if you have a patient whose battery is near electric replacement, whose battery is near depletion, that person in the MRI could tip that battery to total no output. And if they're at all close to dependent, that could be problematic. So patients that are near electric replacement, we would not subject them to an MRI until we had replaced the pulse generator. The most recent document is from last year. This is the consensus statement from HRS. I was privileged to be on this, but I must say this was one of the most contentious consensus documents I've ever participated in. I think in large part because it was half radiologist and half cardiologist, and we weren't always speaking the same language. But as you can see from the e-publication date at the bottom, this is an exhaustive paper. It's something like 60 pages long. And I don't think there was anything that we didn't discuss or document, but very carefully covers exposure to MRI, how to handle it, CT, and radiation. I just want to mention radiation therapy briefly because this falls under the EMI umbrella to some extent. I will not go through this algorithm, but I do want to point out that from that consensus statement that was published last year, a long section on management of patients with devices who are undergoing radiation therapy. This is just one of the algorithms. You know, years ago, whenever we had a patient who had an implantable device and they were going to have radiation therapy anywhere close to that device, we would relocate the device. Most commonly, unfortunately, it was in women who developed a breast cancer on the ipsilateral side of the device. We no longer do that. As you can see in the statement on the right-hand side, relocation of the device is not recommended for devices receiving a maximum cumulative incident dose of radiation of less than 5 gray units. So there are many ways to look at this. This is a publication that's now 3 years old, but it's an excellent article. Now if I have a patient undergoing radiation therapy, the first thing I do is talk to our radiation therapist and physicist about what the dose will be. I then contact the manufacturer who has recommendations for their specific models. So for example, here are recommendations from Biotronic and Boston Scientific, and here from Medtronic and St. Jude. So no longer is it necessary to absolutely relocate the pulse generator, and I would say that the vast majority of the time now, there is no need. Very briefly, for non-hospital sources, not a lot that you and your patients have to worry about, but this is often where you get the most questions from your patients. There are specific work environments, there are uncommon environments where there can be problems. There are lots of things that can cause single beat inhibition, and you don't even want to bring those up to the patient because they just make them anxious. But there are a few things to mention briefly. One is cellular phones. Initially, there was huge concern about whether this would cause interference, but they simply don't. The only thing I still tell patients is that if they're carrying their cell phone turned on, as most people would, I wouldn't carry it directly over a device. Other than that, no concerns. This is a very old case report that I'll go through very quickly. I still think that it's valid. It was published in the New England Journal almost 20 years ago. But this is a pacemaker-dependent patient that was in a department store. And in the beginning, you can see that he was ventricularly pacing, and then some interference develops, which is detected and leads to, and leads to can you just put it back up and advance it? Yep, thanks. Leads to a shock at the beginning of the second panel. Again, starts to redetect this noise, shocked again, starts to redetect, at which point a nurse that was standing close by and shopping pulled this man away from the storefront near the door where he was laying. This was the anti-theft equipment, the electronic article surveillance equipment, and we know that it can be a problem. I have seen patients who have been reprogrammed by anti-theft equipment in a library or a store, but the most important thing to tell patients is that they should just walk right through, even if they're slow, even if they're using a walker. If they walk directly through, don't linger, don't lean on the device. That is the mantra. They will be fine. So, in conclusion, ladies and gentlemen, for electromagnetic interference and what you tell your patient and what you need to do, patient education is key. If there are things they need to know about, make sure they know about it, but don't go into all of the potential causes of single beat inhibition. There are excellent consensus statements available for management of these patients. I've mentioned two. One is the perioperative period document by Heart Rhythm and the Anesthesiology Society. The other is the recent HRS document that covers both MRI exposure and radiation therapy. Pulse generator shielding continues to improve, which allows a greater level of comfort, but new sources of EMI are constantly appearing in this wireless environment, and they need to be evaluated specifically for device interference before your patients can be safely exposed to them. Thank you very much.
Thank you, Dr. Hayes. I think we actually have time for one or two more questions.
There's one more free. I mean, they do that. Why do you want to? There are machines, but not everywhere. But safe, MR safe devices.
Sure. Airport security screening is one that comes up with patients a lot. If the patient were to inadvertently go through the screening, it's not an issue. If they went right through, they may have single beat inhibition, but it would likely set off the alarms because of the method. So using a wand is appropriate, and the wand has been tested and is completely safe for device patients. Good question.
I actually had a quick question. Whenever I review these documents, one of the main things it says it's really important to have a team whenever you are trying to decide what's the best thing to do for this patient. What unfortunately usually happens is you get called last minute, the patient rushing to a procedure. In your experience, have you found a better way to assess this or to avoid these emergent situations where you randomly get called with a patient, and because you need time to decide what the best thing to do for the patient is. And
because of the echo, I want to make sure I heard your question. You're saying that for an urgent situation,
we're just how to properly address these situations as they happen in the hospital, because unfortunately they're not usually routine and scheduled, and you just get bombarded by these patients at random times, and you try to reassure the team and the surgeon and the anesthesiologist, but they're always worried and they're afraid to use magnets. And I was just wondering from your experience if educating them, giving them talks, or just having a more standard approach has helped.
We have tried and have on a fairly regular basis, maybe once per year, tried to be part of the anesthesiology conference or the surgical conference just to give them an update on how to manage these. We are fortunate in that at our institution, as opposed to most in the US, we don't use company personnel. We have all of our own trained nurses that are device experts. So we are usually able to get there to handle it. The other thing is that as remote monitoring continues to improve, there will be additional ways remotely, even within the institution, for us to assess that patient from the OR into the device clinic to avoid somebody needing to run there emergently.
Perfect, thank you very much. Okay, thanks. So next we have Dr. Erik Alben from Zwolle, the Netherlands. He's a cardiac electrophysiologist and director of cardiovascular research. He's going to be talking about sudden death in young patients, mechanisms, sport participation, and prevention.
Okay, thank you very much. It was a joy to listen to the previous presenters. I think most of you is a bit saturated, so I will do my best to attract your attention. I would like to thank, first of all, Dr. Nidal and the Congress organization for this invitation. It's a really very nice Congress with great presenters. The topic is on sudden cardiac death in young people, mechanisms, sports participation, and also how to prevent sudden cardiac death. First of all, Dr. Goldhaber already pointed out, we are sitting the whole day, and that's a risk factor. So the lifestyle is related to cardiac arrhythmias. So sitting is the new smoking, and as we all know, sedentary lifestyle is killing. So we should, put some time during these sessions to move, to get some little exercise. The other thing is that, and that's not only in the Western world, but also in the developing countries, is obesity is really a very serious threat. On the other hand, we have patients and also people, especially in the Western world, who are doing extremely, competitive sports, and that's also a risk factor. So it's very important to keep a good balance. I will go through with you on the incidence of sudden cardiac death in young athletes, how often and in which athletes, and also do we have to perform screening in these people, and briefly on hypertrophic cardiomyopathy and sport, and what to do in case you encounter a person who develops sudden cardiac arrest, and then conclude with some take-home messages. First of all, I would like to start with an ancient picture. So, who is this guy? Well, he's from Greece, and his name is Herodotus. It's a long time ago, 480 before Christ. And he was a tutor of Hippocrates. And he is the founder of sports medicine. And he was a sports teacher and physician. And this scientist, he assumed that bad health was a result of imbalance between diet and physical activity. And he suggested as a remedy a strict diet, constant physical activity, and regular training. So one of his recommendations was to walk. And he recommended to walk from where he was located, Megara, to Athens. And I checked on Google Maps, and it's a distance of 37 kilometers with also some trajectories with ferries. So this is quite a distance, and I think nowadays none of us is walking that much. And to come more to the Middle East, I found this from Rumi, that your heart knows the way, run in the direction. So we have to run, and that's also what ancient people from the Middle East tell us. We all know that regular exercise is beneficial in healthy people, but also in patients with heart disease. Exercise can induce cardiac remodeling depending on the intensity of the exercise. So this exercise-induced cardiac remodeling can be deleterious, and it is important for us as physicians to look for deleterious effects and to prevent it. It depends on how the exercise is performed. So we have the dynamic and the static components. And if we look at what happens to the cardiac remodeling, in case of the static performance, you get concentric LV hypertrophy. And for the dynamic exercise, it causes more dilatation. As you all know, the sports people are not black and white, and they are not a standard type. So you have them in all kinds of sorts. This is an EKG from a black adult, and this is actually normal, within the normal limits, with these prominent negative T waves in the precordial leads. So in people who are athletes, you see reversation abnormalities which are within the normal limits. The question is, what is normal? So that depends on the intensity of the training in these athletes. So depending on what kind of sports they're associated with, and also the intensity and the duration. So we start with the normal morphology, and depending on what happens is you can get left ventricular hypertrophy with voltage changes, but also dilatation with left atrial and right atrial enlargement, but also changes in the sense of a right bundle branch block, especially in endurance sport. There are criteria, ECG criteria in athletes, and this is one of the consensus documents, and I think it's important to read this document. I will go through the document briefly with you. As you can see here, there are some normal ECG findings, like increased voltage, incomplete right bundle branch block, T-wave distortion in the precordial leads. But what is abnormal is, for example, complete left bundle branch block, ventricular pre-excitation, QT prolongation, Brugada ECG, etc. If we look at the cause of sudden death in athletes, then we see in several papers that in quite a number of patients that there is no identifiable cause, and 1/3 is left ventricular hypertrophy, coronary abnormalities, and ARVC in some patients. This is a very recent article on sudden cardiac death during participation in competitive sports. It's from Canada. It's a retrospective analysis of the national database, and they included individuals aging 12 to 45 between 2009 and 2014, and the follow-up, it was 18.5 million person years, and they saw 74 sudden cardiac death events, and of these, only 16 were related to competitive sport. So the incidence is 0.76 per 100,000 athlete years, which is really very low. Of these 16, 3 were ischemic, 6 were primary arrhythmic, 2 coronary anomalies, 3 commotion disorders, and 2 hypertrophic cardiomyopathy and non-ARVC. So 80% cannot be predicted with conventional pre-participation screening, family history, physical exam, or ECG. This is a famous player, Miklos. He was a football player, Benfica, and he died of ventricular fibrillation, and the underlying cause was hypertrophic cardiomyopathy. So if you see this during a match, it's really very dramatic, of course. And how often is hypertrophic cardiomyopathy related to sudden cardiac death? In this analysis, it's 1/3 of the patients, and hypertrophic cardiomyopathy in the Western world is one of the most prevalent genetic cardiac diseases, and the incidence is 1 in 500 in the US. So what about hypertrophic cardiomyopathy and competitive sports recommendation? In general, patients with HCM phenotype should not participate in most sports, exception those with low intensity. Asymptomatic patients with a positive genotype for HCM with no LV hypertrophy, no family history of sudden cardiac death may participate in competitive sports. The level of FSC. It is important to recognize that pharmacologic agents or prophylactic ICD should not be used to participate in competitive sports. What about genetics? Hypertrophic cardiomyopathy is an autosomal dominant disease caused by mutations in sarcomere and disc genes. And genetic testing in these patients, this bit overlap with Dr. Swoll, so I will go through this fast. Can identify 50 to 60% of patients. Does not provide a reliable risk certification or identify high-risk patients if positive for hypertrophic cardiomyopathy. And the role of screening is actually to identify potential at-risk relatives for hypertrophic cardiomyopathy if a mutation is identified in a patient. If no mutation in a relative, then no further testing is needed. If mutation is identified in a relative, there's a high likelihood of developing hypertrophic cardiomyopathy, and of course these patients should be followed. What is the role of testing, genetic testing in relatives of patients with hypertrophic cardiomyopathy? I think it should be performed if possible. We should perform an echo pre-adolescents if interested in competitive sports. Without genetic testing, repeat echo in 5-7 years. If positive genetics but negative echo, then the echo should be repeated every 2 to 3 years during adulthood. And if the genetics is negative, then no further testing is required, of course. So how can we differentiate athlete's heart from hypertrophic cardiomyopathy? We have to look at the thickness of the left ventricular wall. If it's more than 15, then it favors hypertrophic cardiomyopathy. If it's less than 13, it might be related to hypertension, especially if the thickness decreases with treatment of the underlying disease. And what is also important is that in patients with hypertrophic cardiomyopathy, you see very pronounced diastolic dysfunction, whereas that is not the case in athlete's hearts. What is the recommendation for prevention of sudden death in hypertrophic cardiomyopathy? Class 1 is avoidance of competitive sports. ICD if there is a history of sudden cardiac arrest or sustained VT with symptoms. We should estimate the sudden cardiac death risk using risk stratification models and re-evaluate every 1 to 2 year intervals or if there is a change in symptoms. And there should be an indication for ICD if the 5-year risk of sudden cardiac death is more than 6%. And ICD may be considered if the 5-year risk is 4 to 5%, and no ICD if the risk is less than 4%. Unless there are clinical features of proven prognostic importance.
To my personal opinion, if you have a patient with the suspicion of hypertrophic cardiomyopathy, you should perform a cardiac MRI. It gives you a lot of information about the location of the hypertrophy, but also on the myocardial perfusion and also the delayed gadolinium-enhanced imaging showing the amount of scarring in the heart. And Dr. Maron published this very interesting scheme that if you have a patient with hypertrophic cardiomyopathy, for risk stratification, if you have 1 or more conventional risk factors and the MRI shows extensive delayed enhancement, then you should consider primary prevention with the ICD. And the extent of scarring is really related to the prognosis of these patients. Last year, a very young player from Ajax, it's a Dutch football team, he collapsed and during a match, and he had sudden cardiac arrest, but this was initially not recognized. So the BLS was not started promptly, and this young player, he developed very severe cerebral damage. So this is a very dramatic situation and caused a lot of commotion in the Netherlands. So what should we do? Start as soon as possible with the chain of survival. So that means that if you have a patient with a suspicion of cardiac arrest, start with BLS and connect the external defibrillator and start the resuscitation. And these external defibrillators, they really are very important in the prognosis of the patients. The earlier you connect and apply therapy, the better the prognosis. That is shown here. So really it's a matter of minutes. If you apply very early, you will have a very good prognosis. If you delay it by 5 or 10 minutes, you see that the prognosis decreases dramatically.
I'm just sorry to interrupt. If you could,
I will. Yeah. It's just Can it go wrong with an external defibrillator? This is a study from the Netherlands, and they analyzed more than 1,000 external defibrillator recordings, and the sensitivity and the specificity are really very high. The rate of inappropriate therapy is very low, and the majority was caused by the operator or the circumstances. Is there a risk of inappropriate resuscitation? We looked at more than 1,700 dispatches, 55% in cardiac arrest, 45% not, and 18% of patients who were not in cardiac arrest, they received BLS. 2% had damage, fractures, but none of them had organ damage. So the take-home message is that cardiac adaptation to sports affects ECG. Sudden cardiac death is very rare in young sporters, approximately 1 in 100,000 person years. The incidence is same in sporters and in the general population, and the conventional screening is not useful. So the first response to an out-of-hospital cardiac arrest is very important. Prompt and appropriate resuscitation saves lives. Context is king. If you hesitate, just do it. Start BLS and connect the AID. That's it. Thank you very much.
Okay, thank you very much. I'd just like to take the time to thank all the speakers and the audience for attending, but I think they need to start setting up for the opening ceremony, so thank you all.
Thank you very much. Just a short announcement. First of all, thank you for your attendance. Just a reminder for the opening ceremony, it will start at 6 o'clock. So we would really be happy if you can attend. There will be talks by the chairman of the conference, the president of Gulf Heart Association, as well as by the president of European Society of Cardiology, ACC, and SCAI. Short talks about it. So, and after that, then we will have the dinner. So thank you very much again.